It's one of the most common and disabling conditions that we see in the office, as Dr. Ash just told us, 2 to 3% of the population, and certainly greater in the diabetic population. Zuckerman sort of put this together in a way that I think is a good consensus statement: condition of unknown etiology, painful restriction in passive and active motion, for which there's no other cause, i.e. arthritis or septic joint, etc., responsible. This is sort of a typical poster child, female predominance in most of these patients, average age 52, they're non-dominant shoulder. There's an association, although it's not causal, with diabetes and thyroid disease, and a third of these patients will develop this problem in the opposite shoulder, although rarely at the same time. Hanifin has enhanced this typical 3-stage classification that we had, modifying it so that there were 4 stages, and you know what those are: the painful inflammatory phase, followed by the evolution of stiffness, and then a period during which the shoulder is stiff but not necessarily painful, and then finally the thawing phase. I'm going to go through each one of those just briefly in terms of the clinical approach. The painful early inflammatory phase, the patient who has insidious onset of pain, it's painful at rest and or at night. It's not true of every patient, but most of them come in pretty uncomfortable. They have painful motion, although if you carefully examine them, they are not overtly restricted at the outset. And this is variable, and it's true individually that you cannot predict the duration of this experience. I've seen patients who had this early painful inflammatory phase with no restriction for over a year, so it's not classic. The freezing phase, they have pain at rest and at night. They have restricted range of motion, and again, variable duration of that experience. In the frozen phase, once it's gotten to sort of the end of the restriction, they don't typically have pain. But when they exceed the limits of their motion and reach out for something suddenly or have their motion forced beyond what they're comfortable, they're going to have discomfort. In the thawing phase, progressive improvement. Most of the data suggests that gradual resolution of their restriction is inevitable in the vast majority of patients. I tell my patients that for the most part, this is a self-limiting disease. Imaging studies, I think, are unhelpful except to exclude arthritis and to look for any other pathology. X-rays are typically not helpful. I think if you get other studies like an MRI, you do get a little bit waylaid because a lot of patients come in and they have pain, they have a torn rotator cuff, and in reality, their adhesive capsulitis is what's mediating their problem, and I think you have to be careful about delineating this out. There are some studies in the radiology literature that suggest that there are specific findings attributable to a frozen shoulder, and I would not make a decision about a frozen shoulder based on any MRI findings. There are a lot of treatment alternatives. The natural history, you have to know as a baseline, is self-limiting, but it is refractory for some patients, particularly those who are diabetics. So we individualize treatment based on the type of patient, the stage at which they present, the duration of their symptoms, the degree of their impairment, how they've responded to the different strategies, and of course evidence-based outcome data is scant, which I suppose allows you to justify almost anything. But I think, having done this for a long time, that non-operative approaches, these are reasonable strategies that can help patients. Obviously, pain medications orally. Corticosteroid injection seems to be pretty dramatic for some patients. Physical therapy, home exercise program. Now, corticosteroid injections, I think that's very effective in the early painful frozen shoulder. It's very uncommon to take a person who comes in and they're weepy, they can't sleep at night, they're really miserable. You give them a corticosteroid injection that they don't have dramatic improvement in 2 or 3 days. Now, some of them will take a little longer, and maybe 3 or 4% of patients I'll end up injecting a second time. But if you've got the diagnosis, they're going to dramatically respond. However, you need to inform them that their motion's not going to improve. This doesn't seem to translate into a difference in the overall natural history of recovery of their motion. Physical therapy, I think, is appropriate for most patients, but early on they're going to be miserable, and it'll be counterproductive if you send them to therapy without being in that freezing phase, getting rid of that inflammatory, painful phase. So I give them an injection. I'll send them to therapy. I'm going to expect the therapist to educate them, to reinforce what I've already told them in the office, and then to devise a program they can carry out at home. And then I tell them to go to therapy perhaps once every 3 or 4 weeks. Until they hit the thawing phase, there's not a lot they're going to get out of being seen. Operative treatment is for those patients who fail to improve. And I don't know if I could tell you that it's failure to improve in motion 3 consecutive months. There's a couple of different definitions of when you perceive the patient has plateaued. But basically, you'd like to operate on the patient who is not improving, but is out of that painful inflammatory phase. If you do an arthroscopic release on those that are still miserable, they're going to be miserable and you're going to be miserable. Manipulation. I think this is of historic interest with the exception of some very few number of patients. You want to do it gently when you do. You do it in a specific order so that rotation is sort of the last maneuver you'll do. There's a variable percentage of improvement, and that reflects the difference in cohort design of these studies. Overall, I believe that there's a number of patients who are better. I don't think 70% improvement is necessarily a very good outcome, and most of these are not controlled. So I think an arthroscopic capsular release is, I hate to use the word standard right across the river from all the people making the decisions, but I do think a release is the definitive approach for patients who have refractory frozen shoulder. The rationale is based on what you observe when you manipulate and put a scope in the shoulder and you see the axillary pouch has been ruptured and tears in the rotator interval, so I think we could see where the pathology exists. And then there's selective release studies that show us the changes in range of motion with various portions of the capsule that have been released. There's really 2 approaches in the literature. One of them is selective partial capsule release, is based on I guess the perception of the treating clinician as to where the restriction is and or the ease with which it was done, or global releases, which go circumferentially 360. This is the technique that I use. This is an example of a 47-year-old diabetic patient who failed to improve over a long period of time. An injection got her out of the painful inflammatory phase, but as you can see in her right shoulder, she's restricted. She's restricted in all planes. She has pain really only at the extremes of motion. She's stuck. Indwelling interscaling block is critical. You have to have good postoperative pain relief. So if you don't have an indwelling catheter, you're not going to take advantage of that. You determine their motion. You look at the other side because obviously you'd like to see what you expect to achieve. And I do a manipulation, but that's just a precursor to the release. In rare occasions, we get back enough motion. It's easy to do so that you don't proceed with an arthroscopic release. That's extremely uncommon. Most patients, if you've selected the right ones, you're not going to easily manipulate them alone. They're still going to have some residual restriction when you're done manipulating them. Positioning is like some of the other procedures. You'd like to be able to see from both sides. Equipment, you have to have obviously a cautery device. These are capsular release forceps that are blunt and allow you to easily channel under the capsule and release the tissue. Now here we're looking from the back in a right shoulder. This is the rotator interval. You see this sort of patchy inflammatory tissue. Sometimes it's white and just chronically scarred. Here's an example of the ruptured pouch. And now we're going to establish an anterior portal. You can do that from inside out or outside in. This is very tight in the front, and Doug Harriman advocated, and I think it's reasonable, to go in the front and release first in the back. So here we are in the back of the shoulder. This is that blunt capsular release forceps. I'm channeling on the outside of the capsule to develop a little plane, and then bringing the biter in and resecting a swath of capsule that's about 3 millimeters broad. And then we use a shaver to remove this tissue. We're not trying to do a capsulectomy and remove everything, but you want to remove a swath of tissue that won't reapproximate. Now once you've done that posteriorly, you're able to better manipulate your scope. So I put it back in the back using switching sticks. We're going to free up so you can identify the upper border of the subscapularis, and you got to remove all the tissue in the rotator interval. You want to preserve laterally the biceps sling. You're not looking to generate instability. And you can see into the subacromial space once you've done this. And now we're going to do our capsular release. We're able to see the upper border of the subscap, and we're going to take this basket. It's just behind us. We're going to take this basket. We're going to go 3-4 millimeters off the glenoid rim, and we're going to resect this capsular tissue until you can see the subscapularis directly underneath it. There's some descriptions of actually releasing the subscap, which I don't really advocate or understand. Now, the inferior capsular release is probably the hardest part of the procedure. We're looking from the back and we have an accessory inferior posterior portal, and we're going in here, and we want to connect the dots all the way along from the front where we did the release to the back where we did the release. And you want to stay next to the glenoid to avoid getting near the axillary nerve. And finally, this isn't really described either, but to get all the way around, you have to go around the top and get the superior capsule. Subacromial space, as you just saw, is rarely involved, so I don't do a decompression. And then we manipulate at the end. Rarely do you get a whole lot more, because even if when you don't use a pump and you just let it on gravity, and even if you do it in a timely manner, extravasation precludes your ability to usually manipulate much better or see where you are. Now we do this as the first case or cases in the morning. The therapist with the indwelling block sees them that day, that usually early that afternoon, and it's really surprising the degree to which when a patient can see that they have painless motion restored, when they go home a day later, they're able to achieve that in their outpatient therapy in a way that they could not have because of the apprehension and pain beforehand. So I think that block is really key. Complications are infrequent. I think the biggest complication is that you don't do a good job or you can't keep it. Neurovascular risk is nominal, but you stay on the glenoid inferiorly. Don't go wandering around in the pouch. Both of the described complications are resolved. Instability, there's exactly one case in one review of outcomes that has ever been described. In terms of partial releases, they have overall pretty good results, but there are some patients who are still restricted, especially diabetics. If you look at those with complete releases, a very small body of literature here too, they have good functional recovery. All these in this one study were improved. I think the value of this study was to say that there's some patients who 3 weeks out have sort of a re-aggravation, and they come in and they sort of seem like their honeymoon's over. It usually settles down, and some of them you may give them a corticosteroid injection. In the diabetic subgroup, recognize that a lot of these patients will not do as well as those who don't have diabetes, so you have to work hard to ensure that you've got a good block and that you get them in therapy postoperatively. So in summary, most of these patients do not require surgery. Manipulation, I think, is insufficient, but is a component of the procedure that involves a pancapsular release, and I think your postoperative pain control is critical for you to be able to preserve the motion you get. Thank you for your attention.